Ever wonder how sight-saving drugs are prepared to be injected directly into the eye? This isn't just medicine. It's micro-precision science where one tiny mistake can cost a patient their vision. From high-stakes clean rooms to life-changing therapies, we're going inside the eye to show you how the world's most powerful intravitreal drugs are compounded. Tiny doses, sterile technique, massive impact. If you're a pharmacist, med student, or just fascinated by what keeps people from going blind, this video is for you. Let's pull back the curtain and dive into the science that protects sight, right now. Every 5 seconds, somewhere in the world, someone is at risk of losing their sight. Diseases like age-related macular degeneration, diabetic macular edema, and retinal vein occlusion don't just blur vision. They steal independence, dignity, and connection to the world around us. But what if we told you there's a way to stop that? Not with pills, not with eye drops, but with tiny, powerful injections, delivered directly inside the eye. Intravitreal injections bypass the body's natural defenses to deliver high-dose medication right to the retina. It's fast, it's effective, and it must be flawless. Because when you're injecting just 0.05 milliliters into the eye, there is zero room for error. Behind each syringe is a pharmacist trained in sterile compounding, an ophthalmologist who makes every microliter count, and a patient who depends on that precision for their sight. In this video, we're pulling back the curtain on what happens inside the clean room, inside the clinic, and inside the eye. This is how intravitreal drugs are compounded. And trust us, you'll never look at pharmacy or vision the same way again. Let's get started. What if a tiny speck could save your vision? Inside every eye injection lies a powerful compound, but only if it's made right. Today, we're pulling back the curtain on how life-saving intravitreal drugs are compounded, and the mistakes that could cost someone their sight. In ophthalmology, intravitreal injections are common, but compounding these drugs isn't just pharmacy work. It's precision, it's sterility, it's a matter of life or blindness. Let's break down best practices, from the clean room to the syringe, so patients stay safe and vision is preserved. First rule: always use preservative-free solutions. Why? Preservatives may extend shelf life, but they can be toxic to the retina. When you inject into the eye, purity is non-negotiable. Second, filter every compound through a 0.22 micron filter. It's your line of defense against bacteria, invisible threats that can trigger endophthalmitis and destroy vision within hours. All compounding must happen in a USP 797 compliant facility. That means ISO classified air, proper airflow, and trained personnel. Sterility isn't a luxury. It's the law of the clean room. Every drug has a clock. The moment it's made, the countdown begins. Follow strict beyond use dating. Expired means unstable, and instability in the eye is catastrophic. Label everything: drug name, strength, lot number, expiry, tech initials. If it's not labeled, it's not traceable. And if something goes wrong, traceability saves lives. When compounded correctly, intravitreal drugs are miracles in a vial. When corners are cut, they're ticking time bombs. Share this video with every pharmacist, technician, and clinician you know, because safe eyes depend on safe compounding. Let's be crystal clear. Intravitreal injections are no ordinary medication delivery. These drugs are injected directly into the eye, not around it, not near it, into the vitreous humor, the gel that fills your eyeball. That's why perfection isn't optional. It's the baseline. Just one microscopic contaminant, one lapse in sterility, and the consequences can be devastating. Endophthalmitis, a rare but catastrophic infection, can blind a patient within days. Not weeks, not months, days. And the dose, it has to be exact. Too much, and the retina can suffer irreversible toxicity. Too little, and the disease continues to damage the eye. This isn't just about drug concentration. It's about molecular level purity. Every solution must be 1. Preservative-free, because even safe chemicals can burn the retina. 2. Particle-free, because one invisible speck can block vision. 3. Sterile, because bacteria love warm, moist environments like the eye. And 4. And clear, because cloudiness isn't just cosmetic. It's a warning. Say yes, it must be perfect. Because when you're working inside the eye, you're not just treating an organ. You're protecting a person's ability to read, to recognize faces, to live independently. This is precision medicine at its most literal. And this is why compounding intravitreal drugs is both an art and a sacred responsibility. Perfection isn't a goal, it's the standard. When infection enters the eye, time becomes vision. Every second counts. Every decision matters. Intraocular infections, like endophthalmitis or fungal retinitis, aren't just serious. They're vision-threatening emergencies, caused by deadly invaders like staphylococcus, streptococcus, pseudomonas, fast, aggressive, devastating, and fungal agents like candida and aspergillus. These aren't just bugs, they're blindness in a syringe, unless you act fast. That's why we don't rely on oral medications, or even eye drops. We go straight to the source, intravitreal injection, directly into the vitreous humor of the eye. It's high-stakes pharmacology. Why? Because what we inject doesn't get filtered by the gut. It doesn't pass through the liver. It lands right next to the retina. And that means every variable must be controlled. We're talking 1. High-concentration drugs strong enough to kill in microliters. 2. Absolute sterility, because contamination equals catastrophe. And 3. Microliter level precision, where a 0.01 milliliter error can blind or cure. This is where science meets urgency, where pharmacy becomes frontline defense against vision loss. So, what exactly is intravitreal compounding? It's the behind-the-scenes process that prepares tiny, potent medications for one of the most delicate procedures in all of medicine. An injection, directly into the vitreous humor of the eye. Why inject straight into the eye? Because some diseases won't respond to eye drops or pills. They need direct action, right where the damage is happening. Intravitreal injections are used to treat 1. Wet age-related macular degeneration, 2. Diabetic retinopathy, 3. Retinal vein occlusion, and 4. Intraocular infections that can destroy vision in days. But here's the catch. When you inject something inside the eye, the stakes go through the roof. Just a single contaminant, one speck of bacteria, and the result could be permanent blindness. That's why these drugs are not just filled at a pharmacy counter. They are compounded inside ultra-clean, sterile environments known as USP 797 compliant clean rooms. Here, pharmacists wear full sterile garb. Every surface is disinfected. Every movement is measured. Every microliter is accounted for. Because inside the eye, there's no second chance. Coming up, we'll take you inside this world of sterile compounding. Step by step, from reconstitution, to filtration, to the final, sight-saving dose. This is how precision protects vision. This is intravitreal compounding. Now let's step inside the cleanroom. This is where life-changing intravitreal medications begin their final journey, from vial to vision. The process starts in an ISO Class 5 environment, a highly controlled sterile hood. That could be a horizontal laminar airflow hood, or a biological safety cabinet, depending on the risk category. Aseptic garb is mandatory. Gloves, gown, cap, mask, every inch covered, every surface disinfected, because even the tiniest contaminant can mean blindness. Now, the core compounding process begins. Step 1. Disinfect the vial stopper thoroughly with 70% isopropyl alcohol. Let it dry. Step 2. Withdraw the drug using a filter needle to catch any rubber particles or glass shards. Step 3. Sterile filter the solution through a 0.22 micron membrane. This removes bacteria and ensures sterility. Step 4. Using a sterile technique, transfer the filtered drug into a 1 ml Luer lock syringe. This syringe must be air-free, exact in volume, and properly sealed. Step 5. Attach a 30 to 33 gauge injection needle, then cap securely. These ultra-fine needles are the only ones safe enough to pass through the delicate sclera into the vitreous body. And finally, labeling. Every syringe is labeled with laser precision, including 1. Drug name, 2. Concentration, 3. Preparation date, 4. Expiry date, 5. Lot number, 6. And the initials of the pharmacist who prepared it. Each of these steps may seem small, but together, they protect a patient's most valuable sense, sight. This is sterile compounding, not just as a procedure, but as a commitment to perfection. What does it take to prepare a drug for direct injection into the eye? Welcome to the high-stakes, zero-error world of intravitreal compounding. Here, the tiniest lapse could lead to blindness, so precision is everything. Let's walk through the real-life compounding process, step by step. First, the garb. This is more than dressing up. It's full aseptic armor, gown, gloves, cap, mask. And everything happens under an ISO Class 5 laminar flow hood or biosafety cabinet. No shortcuts. No compromises. Next, disinfection. Every vial stopper is scrubbed with alcohol like a surgical site, because even one contaminant can spell disaster inside the eye. Using a filter needle, the drug is drawn up, catching any particles or rubber shavings. Then it's switched to a fine gauge needle, typically 30 to 33 gauge, perfect for ophthalmic injections. Precision at the microliter level. Now comes aliquoting. Each dose, typically just 0.05 to 0.1 milliliter, is carefully transferred into 1 milliliter Luer lock syringes. Every drop counts. Every syringe is traceable. Once prepared, the syringes enter the cold chain, stored at 2 to 8 degrees Celsius, and that temperature must be maintained right up to the moment of injection. No temperature spikes, no thermal stress, just cold, clean control. And for high-volume batches, or when protocols demand it, samples are sent for sterility testing, ensuring no bacteria, fungi, or endotoxins made it through. Because in ocular therapy, safety isn't a feature, it's the foundation. From gowning to labeling, from sterile drawer to refrigerated storage, this is how professionals protect vision, one syringe at a time. The process is intricate, the stakes are high, and the impact is profound. They're small, precise, And they've revolutionized modern ophthalmology. Meet the unsung heroes fighting to preserve vision every day. The anti-VEGF superstars. Ranibizumab, aflibercept, bevacizumab, brolucizumab, faricimab, conbercept. These aren't just names on a vial. They're vision-saving molecules used to treat millions of patients worldwide. How do they work? By blocking VEGF, vascular endothelial growth factor, a protein that fuels abnormal blood vessel growth and leakage in diseases like 1. Wet age-related macular degeneration, abbreviated as AMD, 2. Diabetic macular edema, and 3. Retinal vein occlusion. Left unchecked, VEGF causes bleeding, swelling, and irreversible retinal damage. But when you stop VEGF, you stop the leak. And you save the sight. Now here's how these anti-VEGF agents are prepared for intravitreal injection. Step 1. Always use preservative-free vials, because preservatives can be toxic to retinal tissue. Step 2. Perform an aseptic draw into a 1 ml Luer lock syringe, with exact control over volume. Step 3. The final dose is just 0.05 milliliters, barely a drop, but enough to hold blindness at bay. After measuring the dose, replace the blunt fill needle with a 30 to 33 gauge injection needle, fine enough to pass through the sclera, and delicate enough to avoid trauma. Storage. These drugs must be kept refrigerated between 2 to 8 degrees Celsius, and used within 7 to 28 days, depending on the molecule and compounding protocol. Every step is deliberate. Every detail matters. Because this isn't just compounding, it's precision medicine for the most sensitive organ in the body. Compounding the perfect intravitreal injection is just half the battle. Now let's talk about what happens after the syringe is filled. Because even the most precisely prepared anti-VEGF agent can fail if it isn't stored correctly. Here's your storage and stability survival guide for the 6 key anti-VEGF drugs. Ranibizumab. Store at 2 to 8 degrees Celsius. It's a fragile protein, extremely sensitive to light. Always keep it in its original box or under protection, because once degraded, it loses its therapeutic power. Aflibercept. Also stored at 2 to 8 degrees Celsius, and it holds well in the syringe for up to 28 days when refrigerated. It's robust, but don't push your luck. Contamination or temperature deviation still means risk. Bevacizumab. The off-label MVP. Stored at 2 to 8 degrees Celsius, but has a shorter stability window, typically 7 to 14 days. It's cost-effective, widely used, but demands precision in handling. Brolucizumab. Handle with care. Store at 2 to 8 degrees Celsius, but use within just 7 days after preparation. It's powerful, but has been linked to rare cases of retinal vasculitis and inflammation. Caution is key. Faricimab. The dual-action innovator. It blocks both VEGF-A and angiopoietin-2, making it a next-gen therapy. Store at 2 to 8 degrees Celsius, and it remains stable for 28 days. Conbercept. The rising star from China. Like the others, keep it refrigerated between 2 to 8 degrees Celsius, and it's stable for up to 28 days. As global approvals expand, you'll be seeing a lot more of it. Cold chain is non-negotiable. A few degrees too warm, and you could be injecting an inactivated drug into a patient's eye. Always check your labels, your fridge logs, and your prep date. Because stability is more than science. It's about protecting sight from the vial to the retina. What if I told you that one of the most powerful weapons in the fight against blindness, was originally designed to fight cancer. Meet bevacizumab, better known by its trade name, Avastin. Once developed to stop tumor growth in colorectal cancer, Avastin is now one of the most widely used intravitreal drugs in the world. Why? Because it targets VEGF, the same protein that drives abnormal blood vessel growth in both tumors and retinal diseases. Here's the kicker. A single 100 mg vial of Avastin can yield up to 40 intravitreal doses. That means one vial can save dozens of eyes, at a fraction of the cost of its branded competitors. This is why we compound it. It's off-label, yes, but it's also life-changing, especially in healthcare systems where cost is a barrier to care. So how do we prepare it safely? Step 1. Work under an ISO Class 5 hood, a sterile airflow environment that filters out 99.999% of airborne particles. Step 2. Perform aseptic aliquoting. Carefully withdraw and divide the drug into 0.05 milliliter doses using sterile syringes. Step 3. Label everything with patient ID, drug name, lot number, concentration, and expiration date. Because even though it's off-label, there's nothing casual about the standards we use to compound it. One error in sterility or dosing could mean infection, toxicity, or vision loss. Despite the risks, Avastin remains the most widely compounded intravitreal drug globally. Trusted by ophthalmologists, relied on by patients, and championed by compounding pharmacists. From cancer clinics to clean rooms, Avastin has found a second life. This time, inside the eye. Steroids inside the eye. Yes. And they're changing the way we treat inflammation where it matters most. Let's explore 5 powerful intravitreal corticosteroid therapies: triamcinolone, Ozurdex, Iluvien, Retizet, and Utic. All used to calm the storm of inflammation inside the eye. When do we use them? 1. In non-infectious uveitis. 2. In macular edema from diabetes mellitus or retinal vein occlusion. And 3. In post-surgical inflammation. Let's start with triamcinolone acetonide, the most commonly compounded intravitreal steroid. Shake the vial well. The drug is a suspension, and particles must be evenly dispersed. Draw up using a filter needle to remove any rubber stopper fragments. Carefully measure and transfer 0.05 milliliter into a Luer lock syringe, then attach a 30 to 33 gauge needle for injection. Precision is critical. You want the dose, not the crystals. Next, Ozurdex. This is not your typical injection. Ozurdex is a pre-loaded, biodegradable implant. Once injected into the vitreous, it slowly dissolves, releasing dexamethasone over several weeks. It comes pre-sterilized and ready to go. No compounding required. Just load, aim, and insert with the dedicated applicator. Clean, consistent, and controlled. Now meet the long-acting heroes: Iluvien, Utic, and Retizet. These are tiny steroid-releasing rods, implanted inside the eye to deliver months, sometimes years, of anti-inflammatory action. Iluvien and Utic can last up to 36 months. Retizet is surgically implanted and lasts up to 30 months. Think of them as slow-release micropellets, embedded within the eye, offering relief without repeated injections. Perfect for chronic uveitis and macular edema that just won't quit. From manual suspensions to implantable devices, these steroid therapies are more than drugs. They're precision tools designed to bring long-term peace to an inflamed eye. Coming up next, the intravitreal antibiotics and antifungals that fight vision-threatening infections head-on. It's big, it's bold, and when gram-positive bacteria try to take over the eye, vancomycin steps in as the giant slayer. Vancomycin is the go-to antibiotic for gram-positive ocular infections, including the toughest players in the game. 1. MRSA, 2. Streptococcus species, and 3. Coagulous negative staphylococcus, a notorious cause of postoperative endophthalmitis. When the stakes are high, as in intraocular infections, vancomycin is compounded with extreme precision. Here's how it's done. Step 1. Reconstitute a 500 mg vial of vancomycin using sterile water for injection. Step 2. Carefully dilute to a final concentration of 1 mg in 0.1 ml, the standard intravitreal dose. Step 3. Filter the solution through a 0.22 micron sterile filter to ensure it's particle-free and safe for direct injection into the vitreous. Step 4. Draw up the dose into a sterile 1 ml Luer lock syringe. No air bubbles, no deviation. Storage matters. Keep vancomycin refrigerated at 2 to 8 degrees Celsius, and use within 7 days of compounding. Don't forget the labeling. Every syringe must be clearly marked with drug name, dose that is 1 mg per 0.1 ml, lot number, preparation date, and expiration date. Because when you're injecting directly into the eye, there's zero room for error. Sterility, clarity, and concentration. They're not just guidelines. They're sight-saving requirements. Vancomycin may have started in IV bags, but today, it fights for vision in microliter volumes. Inside the eye, where every molecule counts. Pseudomonas. Enterobacter. When gram-negative invaders threaten the eye, there's one antibiotic that rises to the occasion. Ceftazidime. Known as the gram-negative specialist, ceftazidime is a third-generation cephalosporin with serious intraocular power, especially against Pseudomonas aeruginosa, one of the most aggressive pathogens in postoperative endophthalmitis. But power alone isn't enough. To be injected directly into the vitreous, ceftazidime must be compounded with surgical-level precision. Here's the process. Start with a 500 mg vial of ceftazidime. Reconstitute it with sterile water for injection, then dilute to a final concentration of 2.25 mg in 0.1 ml, the standard intravitreal dose. Next, pass the solution through a 0.22 micron sterile filter. This removes particulates and pyrogens, making it safe for direct intraocular use. Ceftazidime isn't just an antibiotic. It's a precision weapon for one of the most delicate battlegrounds in the body, the eye. All of this must be done inside an ISO Class 5 laminar flow hood, under USP 797 aseptic technique. Every drop, every movement, must be sterile, measured, and meticulous. The filtered solution is then aliquoted into sterile 1 ml Luer lock syringes. Capped with 30 to 33 gauge injection needles, properly labeled, and stored at 2 to 8 degrees Celsius. When refrigerated, ceftazidime remains stable for 7 to 14 days. But check your facility's policy and beyond use dating guidelines. Pro tip: ceftazidime is often combined with vancomycin in empirical therapy, targeting both gram-positive and gram-negative bacteria before culture results come in. Why? Because in an endophthalmitis emergency, waiting could mean permanent vision loss. When bacteria resist the usual suspects, amikacin steps in. It's a broad-spectrum aminoglycoside, and a reliable intravitreal option when others fall short. Why amikacin? It's often used when there's resistance to gentamicin or tobramycin, especially in post-surgical infections or traumatic endophthalmitis. It hits gram-negatives hard and fast. Compounding amikacin. Precision is everything. Here's how it's done safely, cleanly, and effectively. Step 1. Start with a preservative-free vial of amikacin. This is non-negotiable. Preservatives can cause retinal toxicity if injected into the vitreous. Step 2. Using aseptic technique, withdraw the drug and dilute it to a final concentration of 400 micrograms in 0.1 milliliter, the standard intravitreal dose. Step 3. Perform an aseptic transfer into a 1 milliliter Luer-Lock syringe, using a filter needle if necessary to remove any potential particulate matter. Every syringe must be crystal clear. Before use, always check for clarity and the absence of visible particles. Any cloudiness, discard it immediately. Storage, keep it refrigerated at 2 to 8 degrees Celsius, and always use within 7 days. Label it with full traceability, drug name, dose, lot number, preparation date, and expiration. And remember, absolutely no preservatives. Intravitreal injections require uncompromising sterility and non-toxic formulation. Even trace contaminants can cause inflammation, toxicity, or worse. Amikacin isn't a first-line choice. But in the right case, with the right compounding technique, it can mean the difference between irreversible damage and restored sight. Coming up next, antifungals inside the eye. How we stop Candida and Aspergillus from stealing vision. Don't blink. You're watching Inside the Eye. Subscribe now. When fungi invade the eye, the stakes are immediate, and the threat is real. Blindness can unfold in days, sometimes hours. And that's when we reach for the antifungal workhorse of ophthalmology, amphotericin B, powerful against Candida, Aspergillus, Fusarium, and other opportunistic fungi. Amphotericin B is often the last line of defense in endogenous or postoperative fungal endophthalmitis. But here's the thing, amphotericin isn't just potent. It's also an irritant. The difference between therapeutic and toxic, microliters. So let's compound it right. Start with the lyophilized powder form of amphotericin B. Reconstitute with sterile water for injection, not saline, to avoid precipitation. Dilute carefully to your target concentration, 5 to 10 micrograms per 0.1 milliliter. That's the safe intravitreal range. Now this is crucial. Gently invert to mix. Do not shake. Amphotericin is fragile, and aggressive agitation can denature the compound. Once fully dissolved, filter through a 0.22 micron sterile membrane to remove particulates and pyrogens. Transfer under aseptic conditions into 1 milliliter Luer-Lock syringes, cap with a 30 to 33 gauge needle, and store at 2 to 8 degrees Celsius, protected from light. Why all the fuss? Because even the smallest error in concentration can result in 1. Retinal necrosis, 2. Vitreous inflammation, or 3. Permanent vision loss. This is not a drug you eyeball, pun intended. You calculate, filter, label, and protect it like sight depends on it. Because it does. Label every syringe with drug name, final dose, lot number, preparation date and expiry. Amphotericin B isn't glamorous. It doesn't come preloaded. But when vision is under fungal siege, this compound is the hero pharmacists quietly prepare in the cleanroom shadows. Next up, voriconazole. The precision antifungal for intravitreal use. It starts with blurry vision, then floaters, pain, and suddenly, a fungal storm threatens the retina. When Candida, Aspergillus, or Fusarium break through the blood-retinal barrier. One antifungal stands between the eye and irreversible blindness, voriconazole. Voriconazole is a broad-spectrum triazole antifungal. And what makes it special? It has excellent intraocular penetration. That's why it's a top choice for intravitreal use in fungal endophthalmitis. Let's talk compounding, where pharmacy meets precision surgery. Step 1. Reconstitute a 200 mg vial with sterile water for injection. Step 2. Dilute to a final dose of 100 micrograms in 0.1 milliliter, the gold standard for intravitreal therapy. Now here's the fine print. Check and adjust the pH to around 7. This is crucial. The eye is sensitive, and acidic solutions can cause burning, inflammation, or toxicity. Filter the solution through a 0.22 micron sterile membrane, then draw aseptically into 1 milliliter Luer lock syringes, cap with a 30 to 33 gauge needle, and label thoroughly. Store refrigerated, protected from light. And here's the catch. Use within 48 hours. Voriconazole is chemically fragile and loses potency fast. Why all this detail? Because a single intravitreal injection must be sterile, balanced, particle-free, and exactly dosed down to the microliter. Any mistake, you're not just risking inflammation. You're gambling with someone's vision. Voriconazole doesn't just treat infection. It buys time. Time for the immune system to respond. Time for the retina to recover. Time for sight to be saved. You've compounded the perfect dose. It's sterile. It's precise. But if you don't store it correctly, all that work can go to waste. Let's talk storage and stability, the final critical step before intravitreal administration. Vancomycin, the gram-positive giant. The dose is 1 mg in 0.1 milliliter. Store at 2 to 8 degrees Celsius. It is stable up to 7 days in the fridge. Ceftazidime, the gram-negative specialist. The dose is 2.25 milligrams in 0.1 milliliter. Same cold storage, 2 to 8 degrees Celsius. It stays potent for up to 14 days. If aseptic technique is flawless. Amikacin, for resistant bugs. The dose is 400 micrograms in 0.1 milliliter. Store at 2 to 8 degrees Celsius. It is good for 7 to 10 days. But check for clarity before use. Now for the tricky ones. The antifungals. They're powerful, but fragile. Amphotericin B, the antifungal workhorse. The dose is 5 to 10 micrograms per 0.1 milliliter. Store cold and protected from light. Use it within 24 to 48 hours maximum. This one doesn't wait. Voriconazole, the vision-saving azole. The dose is 100 micrograms in 0.1 milliliter. Again, refrigerate and shield from light. It is stable for just 48 hours after compounding. Remember, intravitreal injections don't get a second chance. Storage is not just a technicality. It's the difference between saving vision and risking harm. Every label matters. Every hour counts. Every degree on the fridge dial can decide outcome or complication. Store smart. Label everything. Stick to the window. And when in doubt, toss it out. Next up, intravitreal antivirals. How we prepare life-saving injections for CMV, HSV, and more. When the retina is under viral attack. There's one sniper in our pharmaceutical arsenal, ganciclovir. Precise, targeted, and vision-saving. Especially for those who need it most. Ganciclovir is the go-to drug for treating cytomegalovirus retinitis, particularly in immunocompromised patients like those with HIV, AIDS or post-transplant. It's one of the few antivirals that can cross into the vitreous and stop the virus right at the source. Let's break down how ganciclovir is compounded for intravitreal injection, step by step. Step 1. Start with the sterile lyophilized powder of ganciclovir. Reconstitute it using preservative-free sterile water for injection. Never use bacteriostatic water. Step 2. Adjust the pH. The goal, around 7.4, physiological range. Too acidic or too alkaline can damage delicate retinal tissue. Step 3. Use a 0.22 micron syringe filter to ensure the solution is sterile, clear, and particle-free. Then, aliquot the drug into 1 ml Luer-Lock syringes at a final concentration of 2 mg in 0.1 ml. Ganciclovir is light-sensitive. Store at 2 to 8 degrees Celsius, and always protect it from light with amber bags or foil wrapping. And labeling is non-negotiable. Every syringe must clearly show drug name, final concentration, lot number, date compounded, and expiry date. Why so much precision? Because with intravitreal injections, the margin for error is zero. Contamination or incorrect dose equals inflammation, toxicity, or blindness. Ganciclovir might not be flashy, but it's a sharpshooter in the fight against viral blindness. And in the right hands, behind the hood, under the laminar flow. It's a lifesaver for sight. Up next, foscarnet, the last resort antiviral for resistant CMV and HSV retinitis. When common antivirals fail, and the viruses get tougher, there's a powerful weapon reserved for the hardest battles inside the eye. Meet foscarnet, the specialist for resistant herpes viruses and cytomegalovirus retinitis. Why is foscarnet so important? Because it steps in when viruses outsmart frontline drugs, providing a second line of defense to save precious vision. Compounding foscarnet for intravitreal injection demands absolute precision and aseptic technique. First, use the commercial intravenous vial formulation as your starting point. Draw up the medication aseptically under ISO Class 5 conditions: sterile, contamination-free, and exact. Dilute the drug carefully to a final concentration of 1.2 mg per 0.1 ml, a dose calculated to be potent, yet safe for the delicate structures of the eye. Then, the solution must be passed through a 0.22 micron sterile filter, removing any microscopic particulates and ensuring the highest level of sterility. Transfer the filtered drug into sterile Luer-Lock syringes, ready for injection by skilled ophthalmologists. Store foscarnet refrigerated at 2 to 8 degrees Celsius, never freezing. Importantly, avoid contact with plastic materials that can leach contaminants into the drug. Glass or compatible materials only. Here's a crucial pro tip. Foscarnet is highly irritant to ocular tissue, so dosing accuracy is absolutely critical. Too much can cause retinal damage, too little may allow infection to persist. Foscarnet might be a specialist, but when resistance strikes, it's often the difference between losing sight and preserving vision. Compounded with care, handled with precision, this drug stands guard deep inside the eye. Not every drug is made for every eye, and some only step into the spotlight when absolutely necessary. Meet cidofovir, a rare but potent antiviral powerhouse with a fierce reputation. Why so rare? Because while cidofovir packs a serious punch against stubborn viral infections, its use is limited by a shadow, retinal toxicity. That means it can harm the very tissue it's meant to save if not handled with extreme caution. So how is this powerful drug carefully prepared? Compounding cidofovir requires drawing only the tiniest volume, typically just 20 micrograms in 0.1 milliliter, because every microgram counts when protecting delicate eye structures. The drug must be absolutely preservative-free to avoid additional irritation or damage inside the eye. Before injection, the solution is sterilized through a 0.22 micron filter, ensuring no impurities or contaminants threaten the patient's vision. Cidofovir is no everyday drug. It's reserved strictly for controlled clinical settings with experienced ophthalmologists and pharmacists on guard. And there's another vital step. Patients must undergo close monitoring of intraocular pressure after injection to prevent dangerous complications, because this drug's power demands respect and vigilance. Cidofovir is a rare gem in the fight against viral eye diseases. Powerful but perilous, used sparingly and expertly. When compounded with precision and administered with care, it offers a critical option for patients with few alternatives. A true last line of defense for vision. Inside the eye, cancer can hide. And when it does, methotrexate becomes our surgical strike. A chemotherapeutic bullet aimed directly into the vitreous. This isn't just another intravitreal drug. It's an anti-cancer agent and immunomodulator used in one of the most sensitive settings, primary intraocular lymphoma. Let's break down how methotrexate is compounded for safe, targeted intravitreal use. Step 1. Reconstitute the lyophilized methotrexate vial using preservative-free sterile water for injection. This creates a clean base solution, ready to be fine-tuned. Step 2. Adjust the final dose to 400 micrograms per 0.1 milliliter, a tiny volume that packs a therapeutic punch without risking retinal toxicity. Step 3. Carefully balance the pH between 7 and 7.4. Because methotrexate must match the body's natural range to be tolerated inside the eye. A misstep here could mean pain, inflammation, or worse. Step 4. Pass the solution through a 0.22 micron sterile filter, ensuring it's free from particulates, pyrogens, and any invisible threats. But here's the catch. Methotrexate is a cytotoxic drug. That means it's hazardous not just for patients, but for those compounding it. Every step must be done using NIOSH-compliant PPE, inside a certified chemotherapy hood. This includes chemo-rated gloves, gown, mask, and full skin protection. And once drawn up into sterile Luer-lock syringes, the doses must be stored in sealed, tamper-proof containers with proper hazardous drug labeling. Methotrexate isn't just about stopping cancer. It's about preserving sight in the face of a life-threatening diagnosis. Every microliter must be prepared with extreme care, sterility, and respect for its power. Next up, melphalan, another cytotoxic warrior used for retinoblastoma and vitreous seeds. When cancer targets the most vulnerable, we fight back with precision, power, and purpose. This is melphalan, a life-saving drug used for retinoblastoma, one of the most aggressive eye tumors in children. Unlike systemic chemotherapy, intravitreal melphalan goes straight into the eye, directly where the tumor lives, with minimal damage to the rest of the body. It's vision-saving. It's life-saving, But it's also risky, and that's why compounding it is a delicate race against time. Step 1. Reconstitute melphalan using preservative-free sterile water. This activates the drug. But from this moment forward, the clock is ticking. Melphalan is extremely unstable, with only a brief window for safe injection. It must be used immediately after preparation. No delays, no room for error. Step 2. Carefully draw the exact dose, 6 micrograms in 0.1 milliliter. This is chemotherapy for a child's eye. Dosing accuracy is everything. Step 3. All compounding must take place inside a certified chemotherapy hood. Melphalan carries a high spill and inhalation risk, so NIOSH-compliant PPE is mandatory. Chemo gloves, gown, mask, and protective eyewear. Step 4. Sterile filter the solution, and gently load into a Luer lock syringe fitted with an ophthalmic compatible needle, usually 30 to 33 gauge. Every step must be aseptic, deliberate, and documented. Storage, not an option. Melphalan's stability is extremely limited. It must be prepared fresh and administered within minutes, or its efficacy fades, and the risk of toxicity increases. Melphalan is more than a chemotherapy agent. It's a lifeline for children fighting eye cancer. Behind every carefully compounded dose is a team of experts protecting a child's vision, and sometimes, their life. When it comes to injecting life-saving medications directly into the eye, there's no room for error. Not just in how we compound, but in how we store and handle each drug once it's prepared. Because in ophthalmology, stability equals safety. Let's dive into the Storage and Stability Command Center for some of the most critical intravitreal antivirals and chemotherapeutics. Here's what every ophthalmic team must know, from pharmacy to the operating microscope. Ganciclovir, the viral sniper. The dose is 2 mg per 0.1 milliliter. Storage is done in the refrigerate at 2 to 8 degrees Celsius. Its stability is 48 hours, but always protect from light. This drug is light sensitive, and degradation reduces its potency fast. Foscarnet, the resistant virus warrior. The dose is 1.2 mg per 0.1 milliliter. Regarding its storage, keep it refrigerated. Its stability is 24 to 48 hours only. Warning: avoid plastic materials that leach. This drug is chemically unstable and irritant, so timing and material compatibility are key. Cidofovir, the rare powerhouse. The dose is just 20 micrograms per 0.1 milliliter. Used in rare cases due to retinal toxicity. Regarding its storage, refrigerate between 2 and 8 degrees Celsius. Regarding its stability, no preservative. Use within 24 hours. This drug is potent, and should only be handled in controlled clinical settings. Melphalan, pediatric precision chemotherapy. The dose is 6 micrograms per 0.1 milliliter. Regarding storage, none. This one breaks all the rules. Its stability is just 1 hour. You heard that right. This is a race against time. It must be used immediately after preparation or discarded. No refrigeration, no reuse, no compromise. Methotrexate, the intraocular immunomodulator. Its dose is 400 micrograms per 0.1 milliliter. Regarding its storage, refrigerate at 2 to 8 degrees Celsius. Its stability is up to 7 days, but must be preservative-free. It offers a longer window, but still demands sterile precision every step of the way. These aren't just drugs. They're tools for saving sight, stopping infection, and fighting cancer, delivered to one of the most delicate places in the human body. Proper storage and stability aren't optional. They're non-negotiable. Inside every eye injection is a drug so delicate, so precise, that one misstep in compounding could cause infection, blindness, or worse. Ever wonder what it really takes to prepare these life-saving treatments? Let's go inside the eye, and behind the scenes, to uncover the hidden science of safe compounding. Step 1. The environment. Compounding intravitreal drugs starts in a tightly controlled ISO 5 sterile area, with continuous air quality monitoring. That means HEPA-filtered airflow, zero tolerance for contamination, and techs trained for aseptic perfection. The tiniest airborne particle, it's a threat to sight. Next, the needle workflow. Always begin with a filter needle to eliminate potential glass shards or particles. Then, and only then, switch to a clean injection needle. This small step prevents microscopic contaminants from entering the eye, and makes all the difference in patient safety. Filtration is not optional, it's critical. For small molecule or reconstituted powder drugs, pass every solution through a 0.22 micron sterile filter. It's the final barrier between a sterile medication and a vision-threatening infection like endophthalmitis. Once prepared, drugs must be stored correctly, 2 to 8 degrees Celsius, protected from light, and never used past their expiry. Even the most carefully prepared drug becomes dangerous if it breaks down or loses potency. Proper storage keeps your compound safe, and your patients safer. To verify safety, sterility testing is done on sample preps, like day 1 cultures for bevacizumab. If contamination occurs, testing helps trace it fast. It's not just compliance, it's a critical early warning system for patient protection. And finally, the paper trail. Documentation is everything. Full traceability, including lot numbers, handler credentials, and cleanroom facility logs, ensures accountability at every step. If something goes wrong, the records tell the full story. Compounding intravitreal drugs isn't routine. It's a high-stakes, high-skill process, and it must be done exactly right. Because these drugs don't just go into the body, they go inside the eye. So whether you're a pharmacist, technician, ophthalmologist, or student, this knowledge could prevent the next tragic mistake. Share it, teach it, and make sure we all keep sight safe. At its core, intravitreal compounding is precision medicine at its absolute finest. Every microgram matters. Every second of sterility counts. Every decision behind the cleanroom glass shapes the outcome of someone's vision, or the loss of it. One misstep, a skipped filter, a missed label, a dirty airflow, and the consequences can be sight-threatening, even irreversible. The stakes couldn't be higher. That's why pharmacists, technicians, and clinicians are the unsung heroes behind the scenes. You may not always see their work, but you see because of it. Because in the world of eye care, knowledge equals safer injections, which equals protected vision. The more we understand, the better we prepare, the safer our patients are. Inside the eye, there's no room for shortcuts. Only skill, science, and an unwavering commitment to sight. Behind every intravitreal injection is a quiet miracle, crafted by pharmacists, techs, and clinicians who follow sterile technique to the letter. One compound, one patient, one chance to protect their sight. If you learned something new today, hit that like button to help others find this content. Got questions? Drop them in the comments. We're fast, and we're here to help. Subscribe for more expert-level breakdowns of pharmacy, ophthalmology, and the science that saves lives. And turn on notifications, because you don't want to miss what's coming next. You just went inside the eye. Now let's keep the vision alive, together.